Consider yourself working as a medical officer in an emergency department, or even if you're working in your outpatient departments, you would come across these patients who would give you a history of the fall, or that is sometimes followed up with the episode of unconsciousness. Now, whenever this happens and you got to examine these patients, that is going to highlight the factors that this particular patient is suffering from right-sided hemiplegia, or even it can be a left-sided hemiplegia that this particular patient may be suffering from. Whatever the case is, what are the notes that you're working on? And what would be your differential diagnosis that you would like to work on? It would be definitely a case of a stroke. Now, when we say that the patient had undergone stroke, we usually have these two typical varieties at our hand. First of all, we can have a patient of ischemic stroke, or either it can be a case of hemorrhagic stroke that we're dealing with. Now, first of all, it's again very important to differentiate between these two categories because the management lines are quite different when we're dealing with these two categories or with these two types of strokes at our hands. On the other hand, even when we are managing these cases, we must know how to prevent further attacks of strokes in these patients. And that is what we'll be discussing over here in this particular lecture that encompasses the prevention of ischemic stroke. So whenever we talk about or whenever we use the word prevention, what comes to our mind is the primary prevention as well as it can be the secondary prevention that we have to cater for. First of all, whenever we use the word primary prevention, we must say that we have evaluated the individual and we have jotted down the risk factors that are present in this particular case that we're dealing with. If the patient is a known diabetic for several years, if he's suffering from hypertension, if he has got a sedentary lifestyle, if there is a past history of smoking, that is all that we need for the categorization. And we have to keep in our mind that we have to slot down this patient as a case of primary prevention because the patient is at a higher risk of getting an episode of ischemic stroke in the near future. So we have to cater for that. We have to educate the patient that you are suffering from all of the risk factors that they're present out there. So there has got to be modifications in the lifestyle as well as that we can even start off with some medications right over here as a part of preventive medicine just to stop any episode of ischemic stroke in this particular individual. Moving on, if we have this patient and if he has already suffered from an attack of ischemic stroke, what are we going to do as a medical officer? We want to prevent any further attacks of ischemic stroke in this particular individual. What are the medications that we can prescribe this individual? What are the lifestyle modifications that we can suggest to this particular patient and that can modify the quality of life as well as the life estimation is also quantified for these individuals after these precautions are taken as a part of secondary prevention in this particular individual. So knowing all of these steps that are regarding the primary prevention as well as the secondary prevention out here, they're going to be discussed over here very briefly and just managing the side effects and weighing the risk versus the benefit ratio that is involving in each of the medications as well as if you're performing any surgical procedure. How can it benefit the patient? What are the percentages of the beneficial ratio that we're going to cater for? And that has even to be educated to the patient as well as to the relatives. Usually these treatments, these surgical treatments, if they are performed or if we are performing the bypass surgeries for these patients, they're quite expensive, they're quite cost effective. So it's again very important just to analyze the cost effectiveness whenever we are planning out the primary prevention or the secondary prevention in these individuals. This cost effectiveness is one of the ways that we have to cater for whenever we have these patients and we are managing their quality of life as a physician or as a clinician. So the general principles that we have to cater for are the identification and the control of the risk factors. As I've already emphasized on the fact that ischemic stroke, whenever we use the word ischemia, it's basically relating to the blockage of the blood flow to a certain area of the brain. And that basically reduces the brain functioning whenever the brain cell damage occurs or the brain cell death occurs in constituents to all of this phenomena. So whenever these cascade of events occurs, whenever there is the primary embolization, the primary thrombotic phenomena that is occurring in the arterial circulation of the brain itself, it can be one of the situations in which the thrombus or the thromboembolic plaque has developed inside the brain circulation, either the middle, the anterior, or depending upon whether it is affecting the posterior cerebral arteries. And it can be even affecting the brain area directly, or either it can be a phenomena which is also known as the watershed phenomena, in which a distant area of the brain is affected whenever there is a blockage of the artery. So it can be one of the scenarios, and on the other hand, we have to evaluate whether it was a distant plaque, and that basically traveled farther away from some distant region. It traveled to the brain circulation. It entered the brain circulation. Before that, obviously, it is going to enter the carotids, and then it is going to go right up to the middle cerebral artery, the anterior or the posterior cerebral artery. So depending upon the situation, we have to evaluate the individual. We have to perform all the baseline investigations for this particular individual, starting right away from the complete blood count, and then the platelet aggregation has to be evaluated by evaluating the LDL count. We have to evaluate the HDL levels, and all of these are going to basically enhance the factors, and we're going to get down or jot down to a definitive diagnosis in this particular patient. Then one of the most important lab investigations are the prothrombin time, and then we have the APTT that have to be performed, and that is going to basically highlight the factors. Depending upon, basically, we are going to highlight whether there are some factors for the platelet aggregation or not. So these are all the baseline investigations that we're going to carry out, and that is going to make it more easier to get to a definitive diagnosis in these particular individuals. And then obviously we're going to carry out the CT scans and the MRIs, and the radio imaging techniques are really important over here. Then again, when we have these radio imagings, either it is a CT or either it is an MRI, we must know how to differentiate between the frank hemorrhages, and on the other hand, we have the petechial hemorrhages, which is a feature of the ischemic stroke. They are quite small, and they're smaller in size as compared to the frank hemorrhages in the hemorrhagic kind of stroke, and they're numerous in number. So this is some of the differentiating factors that you have to be quite well versed with whenever you're differentiating between these two kinds of stroke. Once you have evaluated the patient and you know for sure that this patient is suffering from the ischemic variety of stroke, you must know how to deal with these patients. For instance, we have to start off with the tissue plasminogen activator, which is one of the treatment guidelines over here. And basically, it is prohibited and contraindicated in the hemorrhagic variety of the stroke. So this is why it is important. The management and the treatment guidelines are distinctly different in both of these two varieties. So it's again very important to evaluate the type of the hemorrhage that the patient is suffering from. Once we have examined the patient and have sent the lab investigations, we even have to educate the patient regarding the risk factors. For instance, diabetes mellitus, hypertension, sedentary lifestyle, smoking, all of these are basically the risk factors, and you have to educate the patient regarding these risk factors if you want to plan out the primary prevention in regards to that. Then obviously, if we have the medical interventions to be done, we can even opt for that. And then we have the surgical interventions that we can opt for. For instance, we have these patients who have the high LDL levels and low HDL levels. For them, we can start off with the medical interventions. A lot of medications out there can be prescribed for such patients, and out of them, we have the anticoagulants. Usually, we prescribe the oral anticoagulants for such individuals. We have a range of oral anticoagulants out there from which we can choose from. There are a lot of trials that have been conducted on all of these oral anticoagulants, ranging from aspirin, we have clopidogrel, we have ticlopidine, and out of them, after all of these trials, a lot of trials that were conducted in US and England, out of which the most notorious were the MATCH1, then we have the SP3, then we have the Charisma, and all of these are the most important scientific trials that were conducted on a lot of subjects. And they were basically done just to enhance the factors, that just to basically weigh the risk versus the benefit ratios among all of these oral anticoagulants. And aspirin can have its own side effects, ranging from epigastric pain and epigastric discomfort. We'll be discussing all of that one by one when we'll be discussing the medicinal view and the medicinal prevention in all of these cases. On the other hand, we have surgical interventions that can be done. For instance, if we conduct the carotid Dopplers for a patient who has come up to you and he has a history of a recent MI, and we want to just evaluate the fact whether he or she is at a risk of stroke, that is obviously going to be at a risk of ischemic stroke, we have to basically perform the Dopplers on the carotids. When you perform the Dopplers on the carotids, what are you looking for? You're looking for basically any plaque that can be subsided in the common carotid artery, or either it can even block out the internal or the external carotid artery. So whatever the situation is, or whatever the location of the plaque is, you have to basically manage the fact, and you have to just know what percentage of the arteries is blocked due to the presence of this plaque. So this is going to be evaluated whenever you conduct this Doppler on the common carotid arteries, as well as the external and the internal carotid arteries. And depending upon the fact, you're going to just evaluate whether you're going to perform the carotid stenting for this kind of a patient or not, or whether you are going to opt for a bypass surgery, which is one of the options, and it is done whenever there is a plaque that is lodging inside the common carotid, the external, or either the internal carotid arteries. So this kind of surgical interventions can be planned and can be managed for patients who have blockages in their arteries, and that can basically subjacently be a part of an ischemic stroke in the near future. Then obviously, most importantly, the lifestyle modifications. A sedentary lifestyle basically makes you more prone to an attack of an ischemic stroke. So you always ask these patients to have a lifestyle which involve some sort of a physical activity. Depending upon the condition of the patient, of course, how much mobile the patient is and how much physical activity he or she can perform, you're going to prescribe some of the exercises that is basically going to prohibit the formation of thromboembolic plaques in the peripheral circulation that can finally obviously dislodge and get onto the circulation of the brain. So all of these modifications are a part of primary prevention whenever you are planning it for the ischemic stroke variety. Now, the condition of atherosclerosis basically makes you more prone to an attack of ischemic stroke. So, atherosclerosis, diabetes, hypertension, these are the major conditions which basically makes the patient more prone to an attack of ischemic stroke in the near future. If a patient is suffering from atherosclerosis, you're going to give him medications, obviously, but first of all, evaluate the risk factors in this particular patient. Whenever you have these patients and you're taking the history, you're going to basically focus on all of these risk factors and then weigh out the risk or the occurrence of the ischemic stroke in these individuals. Older aged individuals are more prone to atherosclerosis and obviously subsequently to ischemic stroke. Diabetes mellitus is one of the conditions which basically predispose the individual to the formation of thromboembolism in the peripheral circulation. Diabetes mellitus, when we talk about it in general, it's basically affecting the larger arteries as well as the smaller arteries of the peripheries. So it is going to affect the major organs of the body involving the heart, brain, kidneys. All of these major organs are going to be affected subsequently if it is going to be an uncontrolled diabetes mellitus or uncontrolled blood sugar levels are seen in the individual. So you basically always, whenever you're going to diagnose the patient, you're also going to perform the HbA1c levels in these individuals. What is it basically? Why is it important to perform this HbA1c levels? It is going to show you the monitoring of the blood glucose levels for the past 6 months. So whenever you're going to basically evaluate the individual, the HbA1c levels are also going to be evaluated even in the newly diagnosed cases or even in cases who are already diagnosed with diabetes mellitus and now they have reported to you in the outpatient departments with the history of atherosclerosis and they are at risk of obviously developing the ischemic stroke in the near future. Then we have hypertension. Whenever we say there is the high systolic or the diastolic blood pressure levels, the patient is suffering from hypertension and he or she is a diagnosed case of hypertension. Even this is a very important and a major risk factor towards the development of atherosclerosis. Now, even this hypertension gives way to an ischemic variety of stroke, and even it can be a cause of a hemorrhagic variety of stroke. Whatever the case is, stroke is going to damage the brain cells and is going to get a final clinical picture out there. So educating the patient is very important over here. You basically counsel the patient that all of these factors are making you more prone to the development of ischemic stroke. And you're at risk that you may suffer from an attack of an ischemic stroke out there. Tobacco smoking is one of a major criteria and it's been involved as a risk factor for the development of ischemic stroke in the near future. Again, packs per year, packs per day, packs per month is the calculation that you have to perform whenever you're taking the detailed history from the individual. Even if the patient is a passive smoker, it's again going to be highlighted in the history. Whenever you're documenting the history, you're going to write it down whether he or she is an active or a passive smoker in the past, or he's actively smoking right now. All of these are going to be documented in your detailed history or in your detailed recount. Abnormal blood cholesterol levels is again one of the feature, and that's why whenever we perform the lipid profile is one of the major criteria that is going to evaluate the risks in an individual and weigh out whether the patient is going to suffer from an attack of ischemic stroke or not. So you have to basically, again, you can also put the patient on medications, or either you can prescribe the patient for lifestyle modifications to have less fatty food. That is what he or she can do as an individual. Oral contraceptives makes you at a risk, the use of oral contraceptives for the past 2 years. So whenever you basically prescribe these oral contraceptives or the patient is on an oral contraceptive, you educate the patient towards the fact that this is making you more prone to the development of atherosclerosis. So you usually ask the patients to have gaps in between and use other methods of contraceptions rather than a continuous use of oral contraceptives on a longer period of time. Then patients with hormone replacement therapy are also at risk for the development of atherosclerosis, subsequently the peripheral vascular diseases, and that can subsequently relate to the development of ischemic stroke in the near future or later in life. We have a lot of inherited disorders, for example, a lot of coagulopathies that are inherited. They have the genetic transfer that is evident in all of these coagulopathies, and that make the people more prone to the development of atherosclerosis, which is in turn related to the development of the episodes of ischemic stroke. So all of these risk factors and the modifications of these risk factors that can be done through the lifestyle modification, it has to be communicated to the individuals, communicated to the patients. And obviously, we can start off with the medicinal therapies that can relate to the lowering of the platelet count or lowering of the cholesterol levels in the blood. And all of these can basically make the person have a better lifestyle. The quality of life can be improved for these individuals whenever we have a strict control of sugar levels. We have the control of the blood pressure monitoring that is carried out for these individuals. In a lot of patients who basically had an episode of ischemic stroke, whenever the low blood sugar levels were maintained, lower than even the normal range, and even the systolic blood pressures were maintained at a lower blood pressure, they basically showed a better outcome. So a lot of researches have been carried out in which you have to modify the secondary prevention from the primary prevention in these individuals. Depending upon the patient, you have to design the management accordingly for certain individuals. Antiplatelet agents are one of its kind, and it's one of the medications that can be used for these individuals as a course of primary prevention. So what basically happens over here is whenever there is a ruptured plaque, what is going to happen, the collagen is going to be activated, the thrombin is going to be activated, and that is going to in turn activate the thromboxane A2. Then there is going to be an uptake of adenosine diphosphate. The platelet coagulant activity is going to be seen after the rupture of the plaque. So the plaque formation, we already studied the factors. What are the initial scenarios which leads to the plaque formation, which leads to the atherosclerotic phenomena? All the risk factors in an individual, we can have an individual risk factor, or it can be multiple factors that are contributing towards the development of an individual plaque. After an event of a ruptured plaque, all of these phenomena are going to take place, and that is going to result in the conformational activation of 2B and 3A. These are the receptors that are present on the cells, on the platelets, and that is going to finally give way to the platelet aggregation. And obviously, after the platelet aggregation, there's going to be a complete blockage of the arterial circulation to that particular organ. So this is the cascade of events that take place. Whenever we use the antiplatelet drugs, this cascade of events is basically inhibited at different levels. It can be the use of aspirin, that is one of the most important drug, one of the most basic drug that we give to the patients who are at risk of developing atherosclerosis or who are suffering from diabetes mellitus or hypertension. We usually prescribe an antiplatelet drug that is a low-dose aspirin, usually 25 mg for these individuals. This is basically a low-dose aspirin which is given to these individuals, and it is used as a part of a primary prevention for these individuals. It is acting at the step when the collagen and the thrombin is activated, and it inhibits the thromboxane A2. This is the step where the aspirin is going to inhibit the whole cascade of platelet aggregation over here. Now, there are a lot of studies that have been going on because the use of the low dose aspirin has its own adverse effects and has its own side effects, ranging from the epigastric disturbances. It can be even the occurrences of ulcerations in a lot of patients. In other trials, basically, even patients presented with GI hemorrhages, that is the gastrointestinal hemorrhages. And when we investigated the patients had been on a low dose aspirin for a longer period of time. So whenever we weigh these risk versus the benefits ratios in these patients, we have to identify whether we want to give aspirin or we want to switch on to some other antiplatelet agent. We have other variants that we can choose from in these individuals, ranging from ticlopidine. It's one of the variant out here, and basically inhibiting the uptake of adenosine diphosphate, and that is one of the major step over here. As you can see, it inhibits the uptake of the adenosine diphosphate, and finally it is going to stop out the platelet aggregation because the receptors are not going to be activated on the platelets. We have a lot of adverse effects that are associated with ticlopidine. Whenever we weigh out these adverse effects of aspirin, and whenever we compare the use of aspirin with ticlopidine, ticlopidine has more adverse or rather a wide variety of side effects over here, ranging from diarrhea, skin rash, even the patients which present to you with neutropenia, or even it can be the thrombocytopenic purpuras that are seen in a lot of individuals. So the adverse effects, the range of adverse effects, as we see, and the picture is quite adverse with patients who have been on a long-term use of ticlopidine. So usually when a lot of researches were carried out, ranging from a research in US which was named as Charisma, then we had a match research which basically was regarding the management of atherosclerosis with clopidogrel in high quantities, and as well as we used and estimated the beneficial ratios of ticlopidine in this trial. It basically enhanced the factor it is better to use a low-dose aspirin rather than ticlopidine. Then on, a lot of researches were carried out, and it basically highlighted the fact that a newer drug, which is basically clopidogrel, which has lesser side effects, that can be sometimes combined with a very low-dose aspirin on the other hand. It is going to basically stop the activation of the 2B and the 3A receptors on the platelets, and finally basically inhibit the platelet aggregation. So it's a newer drug, and it has its own side effects out there. But basically, there is a better bioavailability whenever we use a low-dose aspirin along with clopidogrel, and it inhibits the platelet aggregation finally. So the quality of life is finally improved for the individuals who are on this regime. And basically, we have other agents out there ranging from dipyridamole, we have the apixaban, which is a newer drug, we have the digatrin, which is another drug. So all of these drugs are the antiplatelet drugs. They are the newer agents. A lot of researches have been carried out on all of these drug phenomena, their adverse effects, and then we also basically weigh the risk versus the benefit ratios in all of these trials, just to enhance the quality of life for the patients who are already debilitated, who have already suffered from a previous attack of stroke, and they're already suffering from a lot of risk factors. So we basically want to have a better outcome for these individuals. The anticoagulation therapy and how is it basically collaborated with embolic stroke. Primary prevention is even needed over here. Whenever we use the word embolic stroke, it is basically referring to the phenomena that basically an ambulance has traveled right away from the peripheral circulation towards the circulation of the brain. It can be an atrial flutter, it can be an atrial fibrillation, it can be a valvular heart disease, it can be a non-rheumatic factors that basically contribute towards the dislodgement of the ambulus towards the brain circulation. Whatever the cause is, if the ambulus is going to travel to the circulation of the brain and is going to cause the brain damage, we must know how to perform the anticoagulation therapy in such cases. Even when we have basically performed the primary prevention for these individuals, we must know how to continue off with these primary prevention cases. Anticoagulation therapy with a VKA is sometimes done, and then we also can choose out from the newer oral anticoagulants. So as we've already mentioned and gone through the use of aspirin, clopidogrel, apiximab, then we have the newer agents, for example, the digrapatrin. All of these are the newer agents, and a lot of researches are being carried on for that purpose as well. The newer oral factor, that is the XA inhibitors, the receptor inhibitors, are put in line as a part of the primary prevention even out here. The use of clopidogrel plus aspirin, as I've already focused on the fact that the bioavailability of these drugs is much improved when they're used in combination. So it's sometimes quite preferred to use these clopidogrel along with a very low dose aspirin. Even the side effects are controlled in this particular way. Then obviously we have the non-valvular atrial fibrillation techniques. We have the CHAT scoring that can be done. If the score is 0, we usually put the patient on an aspirin or no antithrombotic drug. Then we have the CHAT scoring. If it is around 1, we usually prescribe an aspirin along with an oral anticoagulant. If the CHAT score is more than 1, we prescribe just an oral anticoagulant, and all of these has to be the criteria in this particular individual. Moving on to the valvular diseases, if the patient is suffering from some sort of a valvular disease, we have to estimate if the patient has a rheumatic mitral valve disease. Or either it can be with the atrial fibrillation, a previous embolization has been performed in this particular patient or not. Atrial appendage thrombus, left atrial diameter has to be evaluated in these cases. It has to be more than 55 millimeters. If this is a criteria and the patient is basically fulfilling this criteria, we usually prescribe the oral anticoagulants for these individuals. On the other hand, if the embolization has been done or the appendage clot is present over there, despite the use of the oral anticoagulant, we usually give the oral anticoagulant such as a clopidogrel along with a low-dose aspirin for these individuals. This was the criteria for these individuals, and then we have an asymptomatic individual suffering from a rheumatic valvular disease. In that case, we usually prescribe no therapy, no antiplatelet therapy has to be given for these individuals. With otherwise cryptogenic stroke, or if it is a transient ischemic attack observed in the individuals, we prescribe a low-dose aspirin just as a part of primary prevention and just to inhibit any episode of a recurrent stroke in these individuals. If the patient is suffering from atrial fibrillation, we are going to prescribe the patient with an oral anticoagulant. Then, if the patient is suffering from a mitral annular calcification, the systemic embolization has been done, or the cryptogenic stroke, or the patient suffered from a transient ischemic attack, we usually prescribe an aspirin alone. Recurrent embolization, despite the aspirin, we prescribe an oral anticoagulant along with that. With atrial fibrillation, we give an oral anticoagulant. If it's a case of aortic valve calcification, if the patient is asymptomatic, no therapy is given, and if otherwise cryptogenic stroke or the patient is suffering from a transient ischemic attack, we give a low-dose aspirin. So you can even evaluate from all of these treatment modalities out there. We're just shuffling on from a no therapy towards an aspirin, and sometimes we have to couple up the aspirin with an anticoagulant, an oral anticoagulant such as clopidogrel with least side effects out there. So this is how you basically weigh the risk versus the benefit ratios in these individuals. A lot of congenital conditions, for example, a patent foramen ovale, if you're dealing with one, if it's a case of deep venous thrombosis or hypercoagulable states, we usually give the oral anticoagulants in these patients. Otherwise, cryptogenic stroke, or if it's a case of transient ischemic attacks, we're going to prescribe the patient with just an aspirin. The anticoagulation therapy that we have to follow in a mechanical heart valve is basically you have to evaluate the aortic positioning, the bileaflet or medrotonic Hall tilting disc with normal left atrial size, and if it's a sinus rhythm that is seen or that is evaluated for these individuals. Then we're going to basically prescribe the patient with a VKA if the INR is between 2.5 and the range is 2 to 3. So this is the ratio, this is the criteria that has to be fulfilled for these particular individuals. Then if the mitral positioning is tilting disc or there is a bileaflet valve that is seen in this mitral or the mechanical heart valve, the VKA is prescribed if the INR is 3 and the range is 2.5 to 3.5 for these individuals. Mitral or the aortic positioning is again examined or evaluated whenever all of these criteria, when you're fulfilling them, they are done on the echocardiogram that is performed. You're looking for the anterior apical myocardial infarct or whether it is a left atrial enlargement that is observed for these individuals. In that case, the VKA is prescribed if the INR is 3 and the range is 2.5 to 3.5. For these patients. You look for the mitral and the aortic positionings. If there is an atrial fibrillation observed, if there is a hypercoagulable state, if the ejection fraction is decreased and there is an atrioventricle defect, then you prescribe an aspirin plus a VKA. The INR is 3 and the range is 2.5 to 3.5 for these individuals. So it's depending upon the studies of the echoes. The systemic embolization, despite the target INR, if it is achieved, you add basically an aspirin or increase the INR for these individuals. This is the criteria. These are the criteria that you usually use in your CCUs or the cardiac care units when you're following them and you're prescribing the patients with the antiplatelet therapy. The anticoagulation and the non-cardiogenic stroke, we prescribe the antiplatelet agents for even these patients. An ASA plus an ASA and a dipyridamole is sometimes given. You sometimes couple up this therapy with the use of clopidogrel, as well as you can start off with an ASA and a clopidogrel as well. So coupling up the therapies depending upon the criterias is one of the ways that you carry out this phenomenon. Now, whenever you perform the carotid Dopplers for a patient who has a recent MI or who comes up to you with a history of a recent episode of an ischemic stroke or even a transient ischemic attack, you perform the Doppler's ultrasound on the carotids just to evaluate the functionality of both of the carotids, the right and the left. It can be the common carotid that is blocked in a lot of cases, or even it can be the branches, that is the external and the internal carotid arteries that can be blocked due to the dislodgement of a large plaque that subsides or that lodges inside the bifurcation or even in any one of these arterial circulations. So whenever you have this finding, you have to give a relative percentage to the blockages as well. And that is going to highlight whether you're going to give out the medical treatment to this particular individual, or either you're going to perform the surgical treatments in these individuals. The endarterectomy is one of the procedures that is carried out for these patients who have basically a blocked carotid, whether a common carotid, an internal carotid, or an external carotid artery. As you can even evaluate over here, this is the common carotid artery, and over here we have the external, and then we have the internal carotid arteries over here. There's a plaque that is lodging the bifurcation as well as a major portion of the common carotid artery, as you can evaluate from here. When we have a cut section and we review this cut section, you can even just have an overview over here that there is a reduced blood flow through this common carotid artery. There is a narrowed artery cross section over here. When you perform this endarterectomy procedure over here, that is basically going to encompass, this diagram is basically focusing on the common carotids that are located in the neck. This is the internal carotid artery. This is the plaque over here. And this is basically the common carotid artery over here. So you perform this incision, you give this incision over here, and that is how you basically remove the plaque from the location, and then you stitch on this incision. The removal of the plaque is shown over here, and this is the incision stitched. But whether you have to perform this surgery or not is again one of the questions that you have to ask yourself as a surgeon. Because there are always risks whenever you're performing this kind of a surgery. There is a risk of a dislodgement of this plaque even during surgery. And the plaques can dislodge and go to the brain circulation and can be a cause of the ischemic stroke in these individuals post-operatively. So this is how you're going to evaluate whether you're going to perform this kind of a procedure on the patient or not. Sometimes it is performed in individuals and it restores a normal blood flow in the common carotids. Then we have the endovascular therapies that are sometimes performed. We can obviously, as they're quite similar to the endovascular therapies that we performed for the myocardium, involving the balloon angioplasty, and we can even perform the stenting techniques as shown over here, and they can be even performed similarly for the common carotid arteries. Bypass surgeries are performed for the carotids, and even the bypass surgeries can be performed for the myocardial tissue. So it's quite a similar phenomena where you perform a bypass surgery for the common carotids if the plaque cannot be removed and it is basically lodging, or it's a bigger plaque that is involving the common carotid artery. Sometimes we also perform the intracranial stenting phenomena. For instance, this basically diagram is showing the intracranial stenting, in which again you can also perform the ballooning angioplasties, as well as you can also perform the stenting phenomena for the cranial vasculature or the cerebral vasculature as well over here. And again, it's quite a procedure. You have to weigh the risks versus the benefits for the patient as well, and whether either it is going to improve the quality of life for the individual or not. So over here in this lecture, we just dealt with the different techniques out there that we can perform to have a primary prevention and secondary prevention designed for the individuals who are at a high risk of ischemic stroke. So that is the end of this lecture. Thank you for watching sqadia.com.